Hello dear viewers, in continuation of this series on antibiotic selection for difficult to treat or the resistant organism, in this video I am going to discuss about antibiotic selection for bacteremia due to methicillin-resistant Staphylococcus aureus infection. In the last part of this video, there are few questions related to this presentation which you can attempt as per your convenience. I am Dr. Sunil Garg and welcome to Essentials of Acute Care. How we define MRSA organism? Infection is defined as MRSA when Staph aureus isolate MIC is 4 or more than 4 microgram per ml. Isolate which are resistant to oxycillin or methicillin are also resistant to other beta-lactam agents including cephalosporin with the exception of ceftaroline and ceftobiprole which are 5th generation cephalosporins. The initial treatment of MRSA bacteremia consists of monotherapy with vancomycin. Daptomycin is an acceptable alternative agent and ceftobiprole is also a potential alternative agent. Following initiation of antibiotic treatment for MRSA bacteremia, blood culture should be repeated to document clearance of bacteremia. Persistent bacteremia means persistence of blood culture positivity after 48 to 72 hours of initiation of treatment has been associated with the increased morbidity and mortality. Failure to clear bacteremia within 48 to 72 hours after initiation of therapy should prompt further evaluation. A favorable clinical response to initial treatment includes clearance of bacteremia within 48 to 72 hours, resolution of fever, and improvement in the clinical manifestation. If vancomycin is not available or patient is intolerant to vancomycin, teicoplanin can be used in place of vancomycin. If patient has unfavorable clinical response, then patient should undergo evaluation for occult focus of infection that may require drainage. The approach to imaging should be tailored to finding on history and physical examination. Persistent foci of infection such as deep-seated bone infection, abscess, retained prosthetic device or endovascular source of infection should be eliminated if possible. Antibiotic susceptibility results on the original isolate as well as the breakthrough isolate should be reviewed carefully for susceptibility to vancomycin as well as alternative agents. Repeated isolation of S. aureus from normally sterile site like blood, despite seemingly appropriate antibiotic therapy, should prompt suspicion for emergence of an S. aureus isolate with reduced vancomycin susceptibility, even if the MIC of the original isolate was within the susceptible range. For patients with persistent bacteremia beyond 48 to 72 hours, in the absence of removable focus of infection, antibiotic failure should be suspected and antibiotic adjustment is warranted. The optimal antibiotic approach is uncertain in this condition. However, options include switching from vancomycin to daptomycin monotherapy or switching to a combination therapy. For patients with bacteremia attributable to a pneumonia source, daptomycin should not be used in this condition. The combination therapy can also be used when patient has no clear source of bacteremia and if patient is at increased risk for poor outcome including critical illness, age more than 65 years, if patient has renal disease or vertebral spine infection, or if patient is injection drug user or patient has received vancomycin therapy earlier. It is suggested to switch from vancomycin monotherapy to combination therapy in such patients. Among the combination regime, daptomycin plus ceftaroline combination is suggested if supported by susceptibility data. Administered combination therapy until bacteremia has cleared with resolution of fever and the clinical improvement. Then complete the remaining treatment with monotherapy with either daptomycin or ceftaroline depending on the clinical circumstances. Daptomycin is bactericidal antibiotic with concentration dependent activity. Dosing for treatment of bacteremia is 8 to 10 mg per kg IV once daily. The daptomycin minimum inhibitory concentration may increase during therapy and may be influenced by prior exposure to vancomycin. Therefore, daptomycin susceptibility testing must be performed prior to therapy and repeated in the event of positive cultures obtained during therapy. particularly if prolonged therapy is administered and or there is microbiological evidence of persistent infection during therapy. Adverse effects associated with the daptomycin include myopathy, peripheral neuropathy, and eosinophilic pneumonia. Serial measurement of the serum creatinine kinase should be monitored at least once weekly, and daptomycin should be discontinued in patients with the symptomatic myopathy and creatinine phosphokinase more than 5 times of upper limit of normal, or in asymptomatic patient with the creatinine phosphokinase more than 10 times of the upper limit of normal. Teicoplanin is a bacteriostatic antibiotic for MRSA infection with a similar spectrum of activity and efficacy as vancomycin. It has a longer half-life than vancomycin and can be administered once daily with more rapid infusion rate than vancomycin. It can also be given intramuscularly. Teicoplanin tends to be better tolerated than vancomycin. Some favors its use for the patient who are intolerant to vancomycin, while others use it as the drug of choice for the initial therapy for the gram-positive pathogens. Ceftaroline is a bactericidal fifth-generation cephalosporin which is used for the MRSA bacteremia. It has activity against MRSA and vancomycin intermediate as aureus infection as well as some gram-negative pathogens. Ceftaroline has in vitro activity against staphylococci with reduced susceptibility to vancomycin, daptomycin, or linezolid. It is currently approved by the FDA for community-acquired bacterial pneumonia with concurrent bacteremia, but not for the bacteremia in other contexts. It means it is not used for the bacteremia if bacteremia is not because of the bacterial pneumonia. Ceftobiprole is a bactericidal fifth-generation cephalosporin like ceftaroline with activity against MRSA and MSSA. Among patients with complicated S. aureus bacteremia, ceftobiprole has been observed to be non-inferior to daptomycin. Linezolid and dadizolid are bacteriostatic agents, and this drug class may have enhanced efficacy against strains producing toxins such as penton valentine leukocidine, alpha hemolysin, and toxic shock syndrome toxin 1. Linezolid has excellent tissue distribution and may be administered parenterally or orally. Its resistance has been observed among MRSA isolate, and the mechanism appears to be via the bacterial CFR gene. The safety concerns limits the extended use of linezolid, and adverse effects include thrombocytopenia, anemia, lactic acidosis, peripheral neuropathy, serotonin toxicity, and ocular toxicity. It can reversibly inhibit monoamine oxidase, and when administered with the serotonergic agents like selective serotonin reuptake inhibitors, it can induce the serotonin syndrome. Here are few questions. You can read questions and its choices and discuss with me. You can write your answers in the comment section box where I will respond to your answers. You can pause the video and read the questions. Thanks for watching this video, and please do not forget to subscribe to this channel. I would, in addition to your answers, appreciate your any feedback and suggestions. And I will see you in my next video on antibiotic selection for the resistant organism.